Okay, so we're moving into our second segment here, and it's a little bit more information as it relates to personal protective equipment. And obviously, we can see from the questions that came in here, between PPE and quarantine and isolation, really that resident placement are two of the bigger areas across the country that there are some questions or some opportunities that we can look at as organizations in the next steps, again, preventing the spread within our organization. So PPE has been one of the most challenging concerns that has been encountered for our healthcare facilities across the country. And it's not just in long-term care, it's in all settings. Supply concerns exist regarding PPE, and in some areas, PPE inventory is great. Other areas, there are still some significant PPE concerns. And considerations and guidance for optimizing PPE is in place, as well as staff training, staff compliance, and also looking at making sure that we don't have any breaks in practice. So in this segment, we're going to provide you some strategies on PPE use, training, expectations, how to audit use, mentor, and support employees to set that culture of resident and state and really staff safety, as well as compliance with facility policies and procedures. So, you know what? You're hearing this term over and over again, this new normal of what we're living here with COVID-19. PPE is part of that new normal for all of us. We see it going out in the community, and we're living and breathing it every day within our settings. How we had used PPE in the past has certainly changed, as we all know. For many of our facilities that don't have airborne rooms, which is most of the facilities across the United States, and then we did not have respirators, and we didn't have respiratory programs with fit testing. And what we did do is we used PPE consistent with the standard and transmission-based precautions for contact and droplet isolation. But now with COVID-19, employees have had to learn a new normal with PPE and living in full PPE in many circumstances all day long. So we've had to learn how to identify our inventory, complete a burn rate on top of it, work with new vendors or many vendors. We had to work with healthcare coalitions and our local departments of public health for obtaining PPE when our vendors were out of our PPE due to this pandemic. We've had to implement contingency and crisis capacity strategies, such as extended use or reuse of PPE when supply is low. Never would we have thought we would be reusing PPE before prior to this pandemic. So PPE today is still and continues to be one of the significant challenge areas for all of us as leaders in long-term care facilities across the United States. So today, in this last segment here, we're going to provide you with those strategies for planning, inventory management, talking a little bit about those policies and procedures, the types of PPE, what is PPE and what is not PPE, the use of PPE consistent with current guidance, education, optimization, and process surveillance.
So we're going to start out first about talking about guidance related to PPE use, because guidance drives our planning, our policies, our procedures, how we optimize, and more. Guidance is available for all facilities from CDC, the Centers for Disease Control and Prevention, and CMS, Centers for Medicare and Medicaid Services, and even our state departments of health, in some cases, offer us very specific PPE directives. The CDC provides clear guidance in preparing for COVID-19 in nursing homes. This guidance addresses areas that we will be going into more detail today, such as inventory management. Are you identifying your current inventory, the rate you are using PPE, and a determination of your need? Do you have at least 2 weeks supply? Identification of sources for PPE and acquisition. As Lisa indicated, vendors, HAI coalitions, new vendor contracts, Department of Health. Just to be sure you're ordering, you want to make sure you are ordering from a reliable source. Next, how are we monitoring our use of supply and proper usage? We also need designation of staff to be able to replenish the supply. And this is an important step to make sure someone is assigned to be sure to replenish when that supply gets low. Also, are we placing trash containers near the room exit in order to discard after doffing? And then, of course, strategies to optimize based upon CDC guidance for surge capacity and the need to prioritize PPE. So as you can see, guidance provides us with several areas we need to follow during this pandemic.
And we talked about guidance before in the first section as how guidance has changed and continues to evolve and change the more we learn about this virus. And on April 2nd, those of us remember that date, CDC put out that guidance on COVID-19 for long-term care facilities that indicated that all staff should wear face masks in our facility, that universal source control. Full PPE should be worn in accordance with CDC guidance, and if COVID-19 transmission occurs in the facility, facility staff should wear full PPE for the care of all residents, irrespective of COVID-19 diagnosis or symptoms. The most recent COVID-19 focused survey for nursing homes indicates that for a resident with known or suspected COVID-19, staff are to wear gloves, isolation gown, eye protection, and an N95 or higher level respirator if available. So face mask is an acceptable alternative if a respirator is not available. So when COVID-19 is identified in a facility, staff have to wear all recommended PPE, as again, gloves, gown, eye protection, respirator, or face mask for the care of all residents on the unit or facility-wide based on the location of affected residents, regardless of symptoms based upon availability. So it's important that the infection preventionist monitors, like Sue talked about before, the CDC, CMS, and State Department of Health websites for any updates and guidance when it comes to PPE.
Planning on our system for PPE management is really an ongoing basis, and that is another key area. We are not yet done with this pandemic, and supply and demand, as we know, can change within a few days depending on your COVID-19 situation. And many areas of the countries are seeing that resurgence. That proactive approach is always helpful when it comes to PPE. Identifying an interdisciplinary team, and that includes frontline staff workers, to be able to assist you in your approach to your PPE supply management. Many times, your frontline staff can provide you with realistic concerns and needs that need to be addressed when planning for our needs. For example, they may be able to tell you if there are concerns with certain supplies such as fit or integrity of a product that can help you to acquire another product that may meet your needs and provide the safety that you are looking for with PPE.
So also part of the planning process is staying on top of our inventory. And many of us are aware that CDC provides that great resource for us, that personal protective equipment, the PPE burn rate calculator, that can be accessed in the web link that you're given here. And you may also be using a process similar to that in your organization, which is okay, as long as you're conducting inventory reviews and calculating the usage, or what they call the burn rate, of your PPE for your organization in order for you to plan and prepare for your PPE needs. It's essential to identify your needs in order to estimate how long your PPE will last in order for you and your team to be able to plan for those needs. It's also very important to identify who will complete that burn rate process, or if you're using another system to determine your inventory needs, who is completing and monitoring the process. And also assigning responsibility, again, like Sue talked about before, for replenishing the supplies on each unit, that it's not locked in the administrator's office or locked in the nursing supervisor's office, that PPE is accessible and available, and that it's replenished routinely. Many organizations do have a process where every shift change that there's a PPE replenishing process and an inventory process. So again, monitoring usage is very important as well.
Policies and procedures are another area with PPE. It's essential that facilities identify that their policies and procedures are consistent with the most updated state, CMS, CDC guidance in order to be able to give good direction for our staff to follow. And then we want to make sure that we provide good training. So examples of guidance will include Universal source control. All facility personnel must wear face masks while in the facility, or respirators such as N95s. And that cloth or homemade masks are not an acceptable substitution for staff when they're caring for residents or their environment unless you have completely exhausted your mask supply and are unable to obtain any. Resident use of masks, we need to make sure that cloth masks, or if you have a surgical mask, are acceptable as long as the resident can tolerate, but residents should not be wearing N95s. And then the selection, the use, the donning and doffing of PPE, including proper sequencing, is essential under your policies and procedures for COVID-19, because COVID-19 is a little bit different. And then signage. It's important that we also have good signage. CMS has given the directive that facilities must ensure all staff are using the appropriate PPE. So therefore, it's essential to address the types, when PPE should be used, and all of the steps. I do recommend CDC guidance. They have great posters that provide step-by-step directions that you can see on the next slide. And as you see here, this is the example of the CDC resource. I love CDC resources because you don't have to reinvent the wheel. They're easy to download. You can use them in your facility as part of your protocols.
And also, as you saw on that previous slide, that CDC resource for use of personal protective equipment when caring for patients with confirmed and suspected COVID-19 addresses the following. And again, knowing the types of PPE, how to use the PPE, and looking at that overall, the PPE process is very important throughout this whole aspect of COVID-19 and preventing the spread. So again, the types of PPE, making sure that you have clean, non-sterile gloves, the use of isolation gowns, making sure you that have face shield or goggles that cover the sides of your eyes, and the use of an N95 or higher respirator when one is not available. We also know that a face mask is considered an alternative.
The CDC and the states have identified PPE alternatives when facilities have exhausted, and I want to make sure that's clear, when you have exhausted your supply. That would include things such as cloth face masks, can be worn by residents and preferably not by staff, bandanas, scarves, rain ponchos, disposable or reusable lab coats, reusable resident gowns, disposable aprons, patient gowns. Many times, some states call them Johnnies. You may be familiar with that. But again, these are not considered PPE and should be very clear to staff that these are PPE alternatives and only for the use by staff after all PPE has been exhausted.
So the strategies, again, as we look at that, we're looking at guidance, we're looking at planning, we're looking at policies and procedures, understanding and knowing what is PPE and what is not considered PPE. Another aspect of the whole PPE process, and who would have ever thought that we have gotten to this point here in the United States, but it is a reality for us, is that optimization of our PPE, because we know the challenges continue to be a challenge in many areas of healthcare. So in order for us and our organizations to be able to optimize, we have to have a solid process for staff direction when supplies are diminished. So facilities will need to have a system to identify, again, that inventory, the burn rate, the need, and then also what our overall capacity is today and in the near future as it relates to PPE. So by completing your burn rate process, like we discussed before, that burn rate process allows you to plan your facility PPE use, identify those procurement needs, determine your inventory levels, and when there is an apparent or identified shortage, you will need to determine what that process is to optimize the use of PPE. So again, before I talk about those different categories of contingency of, of optimizing PPE, it's very important in this whole PPE process that we as leaders document where we are at as it relates to PPE and why we made the decisions that we made for the PPE use within our organization. Because If we do become short in supply, we will have to utilize our optimization strategies. And as we all know here, this is the CDC website here that talks about the optimization strategies that we can use. And there really are three general strata to really describe our surge capacity that will lead to measures to conserve and prioritize our PPE. So the first strategy, or the first general strata, is conventional capacity. And what this is these are strategies that should already be implemented in general infection prevention and control plans in our healthcare settings. This is what we are used to. Now, if we start seeing some shortages, and based upon our burn rates, we see shortages, we might need to move into what's called contingency capacity. And what that is we have documented, like Sue talked about, those policies and procedures, and we have processes for this. If we get into shortages, contingency capacity says that those are strategies that can be used temporarily during periods of anticipated PPE shortages. And then if we get into crisis capacity, and that is when those are strategies that can be used when supplies cannot meet the facility current or anticipated PPE utilization rate. So it's used during periods of known PPE shortages. Crisis capacity strategies should only be implemented after considering and implementing conventional and conventional and contingency capacity strategies. So discussions to implement contingency and crisis strategies are based upon assumptions that our facility understands that our current PPE inventory and supply chain, that we understand our burn rate, and that we are also in communication, with our local health departments, our healthcare coalitions, the state departments, to identify if we have additional supply needs, and that we've already implemented conventional capacity measures, and that we as a facility have provided our staff with required education and training, including having them demonstrate competency on donning and doffing with any PPE ensemble that is used to perform their job responsibility, such as providing resident care. So again, it's important that we as an organization have good systems in place and processes in place for optimizing PPE, and that our team and our staff understand when we're in conventional capacity, contingency capacity, and crisis capacity.
So then once we have our systems in place, education and verification of competency for all departments are going to be crucial components to compliance and are going to be instrumental in the prevention of spread of COVID-19. Having those trained leaders on all shifts to be able to not only train, but retrain, and to take the time to really observe where there's potential gaps in understanding in order for staff to do it right all of the time. So remember, when providing that education and keeping staff up to date, it's a good idea to use different modalities of education and communication. So take a look at what is being trained, how the training is occurring, and how your staff is responding, because we want to engage staff at all levels to assist with any innovative ways to train what is needed while not overloading staff. So a few examples might be just that ongoing education, learning management system, staff huddles, memos, and those types of things. And that ongoing education, demonstration, return demonstration on an ongoing basis is instrumental. And then process surveillance is, again, how your staff are following their policies and procedures. So your PPE audits can include how they choose, when they put on their PPE, donning and doffing and sequencing, the do's and don'ts, discarding and optimizing. And that's going to be important because they can help you then with ongoing education and quality improvement.
So when we're working with our staff and we know that there is a lot of PPE fatigue out there. All of us have been in our facilities and working with this since February and throughout the United States, obviously through today. And there has been a lot. Who would have ever thought that we'd be working in full PPE all day long? And many of our staff are working extra shifts and longer shifts. So they're dealing with dehydration. They're dealing with the excessive heat. As you can see here on the screen, we're dealing with skin concerns and other things as it relates to the full use of PPE within our organizations. So again, we have to look at ways as leaders, and part of this whole strategy of making sure that our staff adhere to PPE use, because again, as we talked in the first segment, that break in practice could um, potentially introduce the spread of COVID within our organization. We need to provide really that supportive and encouraging environment for our staff and our members. And it's part of that supportive work culture, which provides that safe environment for our staff to openly discuss their vulnerability, their stress, their burnout, and other barriers to their well-being. Having those hard conversations with our team members, and that can be one-on-one conversations, can be in small groups, could be that you as a management team break up and say, we're going to go across different shifts and throughout different departments and on weekends, and talking with our staff and really seeing how they're doing, not only through that process surveillance audits that Sue talked about. We can use that time. We're going to be monitoring the adherence for PPE utilization, but also spend that time to really talk to our staff and have those conversations. Do the staff have access to the appropriate PPE at all shifts, all departments, 24 hours a day, 7 days a week? Do they understand really those strategies for optimization and optimal use? Being exposed to COVID-19 at work and taking that infection potentially home to their families, that is a large concern with our staff. And we've been dealing with this since March and continues to be a concern as we're seeing the increase of community positivity across the United States. Also having those conversations and open conversations with our staff on how to overcome some of those challenges with wearing PPE. Like I talked about, the heat, the pressure areas, time constraints, and exhaustion. So including our frontline workers in those conversations can assist us in really providing a better understanding of how we can support our team members across the boards and across all departments, and be able to troubleshoot those concerns that they have, and working together as a team to be able to support each other as we continue to evolve throughout this pandemic. So Sue and I, we did go through a lot of strategies today and a high overview of those strategies. We went through a lot of depth of information really in a short period of time. And we know that we want to make sure that we have good policies and procedures in place, that we plan for PPE utilization and the process, that we understand our inventory process, our burn rate process, and as well as the replenishing process in our organization of PPE. We also want to make sure that we're working together and looking at that comprehensive training that Sue talked about, being creative in our approach for education and training. We've done a lot of education on PPE utilization, a lot of education on COVID-19 in our organizations, but now is the time to work with our team and find a creative way to, again, get it first and foremost in front of our brains, especially as we're all dealing with COVID-19 fatigue and PPE fatigue in addition. And again, making sure we have someone or a couple of individuals that are monitoring the guidance and those changes and the updates that are going, and making sure that it's not just the infection preventionist that's doing the process surveillance audits that Sue talked about, that it is a team approach. We can utilize some of the tools that are available to us. We can also use the COVID focused survey tool, which is a real good self-assessment tool, but there are also great audit tools that are available for us as we're looking at PPE sequencing, optimization, and appropriate use. And again, creating that supportive and cultural, that culture within our organization, so that our team feel comfortable to say, you know what, I'm just having a hard time right now, or I'm really having difficulty as it relates to utilizing my full PPE, on my 8-hour shift here. What can we do together to work at and looking at potential obstacles and how we can work together as a team? Again, having that good guidance, having that good support and systems in place in order to reduce and prevent that spread within our organizations. So Sue and I wanted to thank you again for spending that time with us, and we want to open it up again for some additional questions.
All right, excellent. Thank you. That was a great talk, Sue and Lisa. I will start with a live question. This is a clarifying question. So did I hear you correctly that when a new resident arrives from the hospital and is placed in a 14-day quarantine, staff should use full PPE and not just the gloves, mask, and eye protection? We thought that adding the gowns was only for isolation.
For quarantine,
This is when a new
new
resident
admission,
arrives.
that person would be on quarantine. Yes, quarantine requires full PPE for COVID because we are ruling out that person could potentially be positive. That's why we put them on quarantine. So it would require full PPE.
Okay, great. Thank you, Sue. There's another live question. How do you feel about reusing PPE while on the COVID units?
So the CDC provides optimization, as Lisa indicated, and depending on whether you're in contingency or crisis capacity, they have identified what they call reused or extended use of PPE that can be used in those circumstances while on a COVID positive unit, which would not be consistent on the other units. So for example, when it comes to a gown, if you're going to be wearing a gown from room to room when you're dependent on the contingency or crisis capacity, it would be only when caring for the resident with the same pathogen, meaning COVID-19. So it would not be allowed then on the other units, for example, because if you have residents that are on quarantine, you're ruling out. So then they would need their own gown for each room, each resident.
Okay, thank you. And this kind of relates to one of our pre-registration questions about how does one don and doff reusable gowns?
So, okay, that brings up a whole nother area where if you take a look at the CDC guidance, and then I do believe even some states have given their own guidance on reusable gowns, and disposable gowns first are not recommended to be reused. And there are circumstances when there is the same gown for the same resident and the same staff that they are utilizing. So they have an area where right outside the resident's room where they're hanging that gown, and it's for one shift, for one person, for one resident and staff. Again, they're going to have policies that are consistent with the guidance on the reuse. Yes. And it should be very prescriptive. It's even a good idea on those policies to footnote the current CDC or CMS guidance so that if anyone does ask, that you can show where that information has come from.
And also making sure that if you are going to be reusing PPE, you have it documented that you as a team made that decision based upon your burn rate, optimization strategies, what your supply is, that you've made that decision, and that you have that, like Sue said, those solid policies. Because just because you don't want to use up all your disposable gowns, so you're going to be using the cloth gowns and you're going to be having one gown per resident, but you have disposable gowns there and you're having a par level sitting there, you have to make the decision why you did that and how you came to that portion of the optimization strategy. So again, documenting why you made that decision.
One other thing I do want to mention, if you are in crisis capacity and you're on your COVID unit and you're wearing that gown between residents, if another resident has another type of pathogen, for example, C. diff, they cannot then use that gown between residents. So there needs to be some really good information on how to do that based on the guidance, and CDC is very clear.
Sue, also, the other thing is you want to talk about the spraying down of equipment, and
yes,
especially
yes.
Reusables.
Yes. There are times when organizations are spraying either certain types of aprons, gowns, raincoat types of PPE alternative, even when they're looking at how they're cleaning and disinfecting any face shields. The one thing I do want to remember is if we're not following the manufacturer of the gown or the face shield or whatever product, and we're not following the directions on the label for the EPA registered disinfectant, what could eventually be happening is you're breaking down the item and the integrity of that protective equipment will no longer work. So it's going to be important that you have good direction from the manufacturer on if this is something that even can be done. Otherwise, you may be disinfecting, but the product no longer provides the protection. So because the integrity of the product is breaking down. So it's important to make sure that you're looking at the entire picture.
This is Alice, if I can jump in, just I'm reading through a lot of the questions now, and there's quite a few about specific scenarios, both with use of PPE by staff, use of PPE for residents, like the residents going out for a regular appointment, or they go out for dialysis 3 times a week, or the residents gone to the emergency room and they've come back, so they were not admitted to the hospital, but people are asking, you know, does that person need to be on quarantine? Do they need to go to the COVID unit, et cetera? So maybe you could just talk about the best resources, because you've given a lot of resources today, but just for those kinds of questions, is there one resource that you think is the best place for people to go for answers to those questions?
CDC preparing for COVID-19 in nursing homes. That would be my number one. And then they have links to the other areas. And I noticed that there were some other questions in there too, Alice. I noticed one had to do with a resident wearing an N95 because their state,
Right.
and if the state has told you, then that's fine. There was guidance early on that there were several reasons. One, of course, is because of the supply of N95s being available and, you know, the availability of residents wearing them and staff wearing it. But if that's a state requirement, I would double check that that's the case. But again, yes, when residents come and go and the PPE, what will happen is if you go to that preparing for COVID-19 in nursing homes and one other, the optimizing PPE, the CDC website, those are the 2 best in my book, because even if you take a look at the COVID-19 focus survey, which gives CMS information, much of that information is very consistent with the CDC guidance.
Great. Both of those links are in the chat box right now.
Yes.
Great, thank you.
All right, thank you, Alice. Here's another question about whether COVID positive residents can use, this is another specific kind of scenario, whether COVID positive residents can use the rehab gym for therapy if staff and the resident are both wearing full PPE.
You know, that's a really good question. And, you know, we have these situations where we have to balance those needs of residents because we are seeing that residents' function is declining, skin integrity issues because they're not out of their rooms and they need that exercise. I think what has to happen is the team needs to balance and have a meeting and talk about, is there anything that we can do in the room that would work the best first and foremost, because as that resident is, if that gym is going through, they have to walk through a unit that is COVID negative, or I think that puts everybody else at risk too. I think we have to look at the bigger picture and see if there's other opportunities, because certainly where those units are located, whether you have to put someone in an elevator, walk them down the hall in a wheelchair, it could be actually more of a risk because we know the spread, and it may be difficult then to prevent the spread.
And then just important to remember that, you know, wherever, you know, with providing the rehab, wherever the location is that the good cleaning and disinfection has to occur.
Yes,
with that.
EPA list N.
Yes.
Mhm.
Okay, thank you. How about, what about medical waste? So is medical waste from suspected, confirmed, or unknown COVID-19 residents labeled as biohazardous or treated as routine medical waste?
That's a good question. And I would have to, what I believe it's routine medical waste at this point. I do believe it's routine, unless of course it fits into any of the bloodborne pathogen type of waste. And I do know also that laundry should be processed the way all of our laundry is, because we're using standard precautions. And so our laundry department should be using proper PPE as well. But I do believe the medical waste, and I will try to see if I can find that really quick while you're asking other questions.
All right, thank you. The next question will be for Lisa. This is one of our pre-registration questions. Can you comment on accessing PPE when no stock is available and declined by the state agency?
That's a really good question. And again, when there's no stock available from like our state agencies, there's different opportunities that we can do as leaders and as teams to get creative, really to find where those opportunities are. I would first start with, and Sue and I have recommend this all the time, start first with your local Department of Public Health. They might know where the additional access is, and they're also involved in many of those conversations that are at the state level that then reach up to the national level. But there's other sources that you can consider as well. Contacting your state provider associations, which is a great resources. Many of them already have GPOs that are set up. They have access to other networks that they're able to help their members as well. Sue and I have done some large state work where the provider association was able to access PPE much quicker than some of the other individual members are, because of their bigger buying power and their opportunity to be able to do that. You can also then, I know the national provider associations also have links and resources for accessing PPE. And then also, like Alice mentioned earlier, is that our hospital partners and our physician partners and our clinic partners have been working together, especially in some of our rural settings. They've been working together on really looking at managing and finding and accessing that PPE. And then also getting to know your peer organizations and getting to know members of this collaborative, of the ECHO collaborative, once you're in your hubs, is another opportunity in working together.
Great, thank you, Lisa. Sue, did you find anything?
I did. Okay, so CDC guidance states that management of laundry, food service utensils, and medical waste should be performed in accordance with routine procedures. There is no evidence to suggest that facility waste needs any additional disinfection. And where you can find that is under waste management. If you scroll down under the CDC clinical questions about COVID-19, questions and answers updated October 5th of 2020. I'll repeat that. Clinical questions about COVID-19, questions and answers updated October 5th, and then you scroll down to waste management.
Great, thank you. Thanks for
You're
looking at it. And great question. Thank you for the live question.
Yes.
One more question for me, and then Alice, we'll see if you have a closing question before we wrap up. But we're still getting a lot of questions in the Q&A about staff who have worked with COVID positive residents and when they can work again with non-positive residents, and also questions about when formerly positive staff may return to work and when they can work with COVID negative residents. Could you comment on that some more?
So I'll start with the one you just finished, the last question. COVID positive staff who follow the CDC requirements for return to work, which is now they prefer the time-based rather than the test-based, that then they can care for residents if they've gone through the return to work. So, and if many facilities choose to put those residents or those staff members on COVID positive units, but they can also work on any unit because they have met the return to work requirements and criteria. Then the question, of course, is when can someone work from a COVID positive to a COVID negative? The best situation is that they continue to work on the unit. If that's not possible, the next best is that absolutely during the shift, they should stay on one unit. So you have that dedicated staff. if for some reason there's an emergency and that is not possible, then they should care for negative residents first before going to the positive, and then not go back to the negative unit if at all possible. That would be my recommendation as the best possible approach.
Thank you, Sue. Lisa, anything to add?
No, that is good.
All right. And Alice, any other questions for our speakers before we?
I just want to thank everybody for the great questions. They're fabulous. And for those of you who I couldn't type fast enough, we will get answers back out to you. Please email us. Thank you so much.
And you did type very fast. Thank you, Alice. Big thank you to our speakers, Lisa and Sue, for sharing their time and expertise with us today, answering all these wonderful questions. Big thank you to Alice Bonner from IHI for answering all of these questions as well and serving as a panelist. And thank you to everyone on the network who joined us today. Please join us again for our next pre-launch webinar session, which will be next Thursday. That's October 29th at 10:30 a.m. Mountain Time, 12:30 p.m. Eastern Time. Please look for the link in the chat box for the survey so you can get your certificate of completion and your CME credit and CEU credit. And again, please visit our website or email us for any more information on these sessions and this program. And we look forward to seeing you all next week. Thank you all. Bye.